This presentation gives an overview of the South Wales programme. It's for members of the public and NHS staff. We're currently in the middle of a public consultation about the future of some hospital services for people living in South Wales and also South Powys. Before we start the main presentation, it's important to emphasise a few facts. This is an 8-week public formal consultation, and the health boards in South Wales are consulting on 4 options for the configuration of 4 specialist services. At this point, no decisions have been made. No hospitals will be closing, and no hospitals would lose their A&E departments. It's also important to say none of our staff will lose jobs as a result of these changes. Indeed, the changes are partly driven by a shortage of staff. We need all the staff we can get in these services. Through consultation, further evidence may emerge, and we will be taking account of that at the end of consultation. We'd be looking for further evidence to show how we could improve patient outcomes as a result of doing something different. What do we want for the people of South Wales and South Powys? Well, what we want is for all people living in South Wales and South Powys to have access to the best possible care whenever they need it, giving them the best possible chance of surviving an injury or illness and the best chance of returning to a full and independent life. This is about providing the best services for the whole of those communities, not just for one community or another. The South Wales programme is unique in NHS Wales in bringing together 5 health boards and hundreds of clinicians to consider how to meet some very real challenges. We're working together to address problems facing some very busy and fragile hospital services. As I said, nearly 300 clinicians have been involved in this, and these are frontline doctors, nurses, midwives, therapists, and colleagues from the ambulance service, paramedics, and they've been at the centre of this work. Quite a lot has been said in the media about managers wanting to change things, but actually these changes have been driven by clinicians wanting to see their services become safe, sustainable, and comparable with the very best. The other important difference is that we're proposing that all 8 hospitals that currently provide these services should work together as a network, providing a consistently high quality of care across South Wales and South Powys, with the fundamental principle at the heart of our thinking that we should provide as much care locally as possible, near where people live, but only if it is safe to do so, and we're concerned that some of our services are not as safe as they should be at the moment. Well, what services are we talking about? Well, we're not talking about all hospital services, far from it. These proposals and the consultation is focused on 4 services. Consultant-led maternity care, that's where a doctor is involved in the delivery of a baby, normally because the pregnancy is in some way high risk. And neonatal critical care, that's care for newborn babies who are poorly and need extra help at birth. The third service that's being considered is inpatient services for children. So that's where children have to stay in hospital overnight or for longer. And finally, the 4th service is what is called emergency medicine, which many of us call accident and emergency. Care for the most poorly or most severely injured patients who require the attention of a specialist doctor. So where are these hospitals currently provided in South Wales? I said they're provided in 8 places at the moment. Those are Singleton and Morriston Hospital in Swansea, the Princess of Wales Hospital in Bridgend, Prince Charles Hospital in Merthyr Tydfil and the Royal Glamorgan Hospital in Llantrisant, the University Hospital of Wales in Cardiff, Neville Hall Hospital in Abergavenny and the Royal Gwent Hospital in Newport. Why can't we carry on as we are? Why do we have to change anything? Well, we know that patients are not getting access to the best care at the moment, and sometimes the outcomes are less good than they should be. We know, for example, that we're unable to meet all the clinical standards that are recommended, the best practice standards that come from the Royal Colleges or from national organisations. We know that patients who are admitted to hospital who are poorly do better if they're seen by a senior doctor, that's a consultant or a senior doctor in training, very early on in their admission. That way, they're more likely to get the right diagnosis, more likely to get the right tests, and more likely to start the right treatment as soon as possible. It actually means sometimes that they're more likely to be able to be sent home again, because senior doctors can be more confident about doing that. We know, however, that although we want to be able to provide that level of service, that we can't do it in the 8 hospitals that we're currently trying to provide these services in. We simply don't have enough senior doctors or senior trainees. This is a problem across the UK for these specialties, but it's particularly problematic here in Wales. We know that we're so short of doctors for some of these services in some of the hospitals that they are at risk of collapsing because we're unable to safely staff the rotas to provide round-the-clock care. So what's the solution? Well, we believe that to provide the best care for all our patients all of the time, and to be able to meet these standards so that we can deliver care as good as the very best anywhere, then we need to provide these services in fewer hospitals, 4 or 5 hospitals across South Wales, providing a network of care for the population of South Wales and South Powys. So what would that mean in practice? Well, it would mean that all hospitals will continue to provide a wide range of care for people locally. The majority of A&E care will continue to be provided locally just as now, because the majority of patients who attend an A&E department don't need to be seen by a specialist emergency medicine doctor. And it means that instead of having 8 hospitals all competing to try and provide the same services, we will create a hospital system where the hospitals are working together so that between them they provide all the care that's required. And we think this will make it much more attractive for doctors to want to come and work in Wales, because they know they'll be able to work in hospitals where the standards are being met and they can provide the very best care. We've said that the 4 services that we're considering need to be all provided in the same places. It makes no sense, for example, to have neonatology in one hospital and the obstetric department in another, or paediatrics in one hospital and the major A&E department in another. So quite early on, the clinicians were clear that these services should all be provided together in fewer hospitals. As I said before, it doesn't mean any hospitals will close. In fact, quite the opposite. It's essential that all the hospitals remain open and are busy if this system is going to work. But it does mean that some hospitals will have a different role to others. In exactly the same way, no A&E departments will be lost, but they will provide different levels of care. The 4 or 5 centres would have the specialist doctors in emergency medicine, whereas the other hospitals in the network would have departments that were staffed with advanced nurse practitioners and advanced physiotherapists, for example, who would be able to provide excellent care to the majority of people who currently attend A&E. This is quite like what happens in some of our minor injury units already, and the feedback from patients is excellent. You may recall that during September to December 2012, we carried out an intensive programme of public and staff engagement about the ideas that were emerging from the South Wales programme. And we're grateful for everyone who took time to attend a meeting or to give us their written feedback. We received lots of very useful contributions, and we've reflected on those and made adjustments to our proposals as a result. There was a lot of learning that came from the engagement, but perhaps the key messages are these. You told us that you understood why we couldn't stay as we are, and that we did need to change how we provided these services. In fact, an absolute majority of people supported the idea of 4 or 5 centres. You did, however, tell us that you, quite understandably, would like us to provide these centres, to have as many as possible, to provide services as locally as hospital and in as many hospitals as we could, provided it was safe. And you emphasised our thinking that safety was the overwhelming priority. You also told us that you were concerned about the impact on the Welsh Ambulance Service, which, during the period of engagement, was finding it hard to meet some of its targets, and you were worried that these changes might make that even harder for them. You also were concerned that the changes that we were proposing might make it even harder for people who live in our less affluent areas to be able to access the services that they need. And there were some general concerns about how people's journey times to hospital would change as a result of these proposals, and particular concerns about the problems of public transport in South Wales, which for some communities are already difficult, and a concern that by having fewer centres, those using public transport would find it even harder. And we've listened carefully to those concerns. During engagement, we explained that 3 of our hospitals in South Wales effectively were already providing these regional centre services. That's the University Hospital of Wales in Cardiff and Morriston Hospital in Swansea, and a 3rd hospital, which doesn't actually exist yet, called the Specialist Critical Care Centre, which is planned to be built near Cwmbran to take over the major acute role from Neville Hall Hospital and the Royal Gwent Hospital. And that has, if you like, been designed to be a regional centre, just as we are proposing. We also used feedback from engagement to find out what criteria we should use to assess any proposals that we were bringing forward, to assess them against. And as a result of that, as well as work with our 300 clinicians, some focus groups with the public, also groups that represent staff in the NHS, and indeed the stakeholder reference groups for the 5 health boards, we came up with 6 criteria for success, and these were, in the order that they were prioritised: safety, quality, sustainability, access to services, equity, in other words, the impact on different communities, and strategic fit, in other words, did it make sense in light of other things that were going on in NHS Wales. During engagement, we said that there were 6 possible scenarios, 6 possible combinations of hospitals to provide the locations for these services. As a result of the engagement and the information that we have obtained during that, and as a result of comparing all the scenarios with the criteria for success, we have now ruled 2 of those scenarios out. And that was a scenario, one of the scenarios that would have had 4 centres. That was the scenario of the University Hospital of Wales, Morriston Hospital, the SCCC, that's the Specialist Critical Care Centre, and the Princess of Wales Hospital, Bridgend, and also one of the 5-site options: UHW, Morriston Hospital, the SCCC, and then the Princess of Wales and the Royal Glamorgan Hospitals. And those combinations of hospitals actually came lowest in the scoring against the criteria, and also failed to meet some of the other essentials. And so we've excluded those, and that's left us with 4 options on which we are consulting. I think it's really important to say at this point that we are genuinely consulting on all 4. Any of these 4 could be the preferred option following consultation. All of the options include the 3 fixed points. That's the University Hospital of Wales, Morriston Hospital and the SCCC. Option 1 has those 3 fixed points and the Prince Charles Hospital in Merthyr Tydfil. Option 2, the 3 fixed points and the Royal Glamorgan Hospital in Llantrisant. So those options are both 4-centre options. Option 3, the University Hospital of Wales, Cardiff, Morriston Hospital, the SCCC, the Prince Charles Hospital in Merthyr Tydfil and the Princess of Wales Hospital in Bridgend. And finally, another 5-centre option, option 4, the 3 fixed points, Prince Charles Hospital in Merthyr Tydfil and the Royal Glamorgan Hospital in Llantrisant. We took all of those 4 options and we assessed them against the criteria for success, the benefit criteria that I listed of safety, quality, sustainability, access to services, equity and strategic fit. And we weighted those criteria based on feedback from the various groups. We've also looked at their impact on patients, particularly in relation to transport and travel times. The Welsh Ambulance Service, who have been partners in this work and in the consultation, have provided their input into the impact for them of the various options. We've looked at the current workforce challenges and how they would be addressed by these different options, but also we've looked forward to the predicted workforce challenges. It's possible to get a sense of what is happening in these specialties and equally what we might be able to do to improve the position by making these changes. And finally, we have done a financial evaluation, but that came right at the end after the clinicians and the other groups had come forward with the options. When we did all of that, one of the options that we're consulting on came through as the one that fitted best the criteria for success and the other criteria that were applied. And this was option 3. Option 3 is the University Hospital of Wales, Morriston Hospital in Swansea, the SCCC to be built near Cwmbran, Prince Charles Hospital Merthyr Tydfil and the Princess of Wales Hospital in Bridgend. We've published on our website, details of which come at the end of this presentation, all of the information that we used to reach that conclusion so that you can look at them and form your own view. So what does this mean for a woman who is pregnant? Well, all those women who currently choose to have a home birth or to have a birth delivered by a midwife in a midwife-led birth centre will still be able to have that done just as they do now, in the place that they would have gone to now. For all women, wherever they're having their baby, their antenatal care and their postnatal care, that's the majority of the care that they receive during pregnancy, would continue to be provided in the same place as now, near where they live. But women who either choose or are advised to have their baby delivered with a medical specialist, an obstetrician available, would need to have their baby in one of the 4 or 5 centres. And this is around 1 in 3 women in South Wales at the moment. And of course includes women who have to have a caesarean section. The majority of women who have an obstetric delivery only spend a night or 2 in hospital, so it would mean some women travelling a little further to have their baby, but they shouldn't be in that hospital for very long. So what does it mean for a newborn baby who requires critical care, so-called neonatal critical care? Well, at the moment in South Wales, we have 3 neonatal intensive care units, one in Newport, one in Swansea, and one in Cardiff. And after much debate, the clinicians have recommended that we keep 3 centres, one for each of the major conurbations. The location of those centres within Swansea and Aneurin-Bevan will change according to plans developed locally by those health boards, but there will still be 3 neonatal intensive care units. Because of that, we're not proposing to consult on that. In terms of high dependency neonatal care, sometimes called level 2 neonatal care, this will be available in the other 1 or 2 centres providing consultant-led deliveries, thus improving the standards and safety for women who are having high-risk pregnancies or high-risk deliveries, where the babies are most likely to need some additional neonatal care. What does it mean for children? Well, of course, most children, when they're sick or injured, are not treated as inpatients in hospital. The vast majority are either looked after by their GP, by a school nurse or by a health visitor, or if they do need to go to hospital, it might be to an outpatient clinic or to have a test or an X-ray. or to go to an assessment unit where they're seen by a specialist, a diagnosis is made, some treatment is started, and after a few hours they're allowed to go back home again. So these proposals are only about those children who need to stay in hospital overnight. Fortunately, that's a very small minority of children who use healthcare. Well, we will continue to provide a full range of outpatients, diagnostic tests such as X-ray and blood tests, and same or next day clinics in all the hospitals that we currently provide them in now. So the majority of children will still be able to get those services in their local hospital. We are looking at how we might safely be able to provide some form of specialist paediatric assessment in local hospitals where there aren't inpatient beds. However, those children who do need to be admitted and stay overnight, that's the most sickest or most seriously ill children, would have to go to one of the 4 or 5 centres, and that's because that way we can provide enough doctors in training and specialist doctors to look after those children safely 24 hours a day, 7 days a week. Finally, what does it mean for the specialty of emergency medicine or accident and emergency? Well, it's perhaps obvious to point out that our A&E departments at the moment in South Wales are all doing different jobs. They are all quite different. Morriston Hospital and the Heath Hospital are very different from the sort of work and the sort of numbers of patients who go to the Royal Glamorgan Hospital or the Princess of Wales Hospital, for example. And the majority of people who go to any of those A&E departments do not need to see a specialist in emergency medicine. Indeed, they will get excellent care and sometimes more timely care by being seen by a specialist nurse or advanced nurse practitioner and perhaps an extended scope physiotherapist who can initiate. We want to make sure, though, that those patients who do need to see a specialist in emergency medicine are likely to be able to see one when they need to. And at the moment, we have some A&E departments where, in theory, the care is delivered by consultants, but in practice there are so few consultants that for most of the hours of the week there is no consultant in the department. Indeed, the only doctors there may be quite junior, reasonably recently qualified doctors who don't have the full knowledge and skills of an emergency medicine consultant. And so we want to put the consultants that we've got into 4 or 5 A&E departments so that if you need one, you are very likely to be able to see one as many of the hours of the week as we can. And we know that that will give better outcomes and make the departments and the care they provide safer. And again, it means that more people will be able to go home from A&E with a confident diagnosis and treatment plan, rather than being admitted as a precaution, which puts further pressure on our hospital beds, which, as everybody knows, have been under huge pressure. So what does it mean for emergency medicine? Well, it means that the majority of people who are acutely unwell or have a minor injury will continue to be able to go to their local hospital just as they do now and receive excellent care. To give you an example, Terry is a painter and decorator who's been fallen off his ladder. And what would happen to him? Well, if he fell a long way or he landed on his head and had a serious head injury, someone would dial 999 and he'd be taken directly, either by ground or air ambulance, to the University Hospital of Wales, which is now where the neurosurgery centre is for South Wales. That way he'd get the very best care from the right people straight away. What if he didn't fall so far, but he did break his leg? Well, he'd need to go to one of the 4 or 5 A&E centres which had consultant specialists in emergency medicine in it. They would assess his fracture. They may be able to treat it in the department with a plaster and send him home. Or if he needed an operation, he'd be admitted to that hospital for an emergency orthopaedic operation, perhaps to put a plate on the fracture. What if he was worried that his ankle was broken, but it was probably just sprained? He could go to his local hospital where he would be seen by an advanced nurse practitioner or a physiotherapist, and he could have an X-ray. And if there was any doubt, those clinical staff could liaise with the specialists in the hospital, with the consultants, we're able to share x-rays and with telemedicine or even just a phone call to get advice to support those departments. So he would get the right care provided for him in that way. So those examples perhaps just illustrate the sort of changes we're describing. This is about all the hospitals working together to provide a network of care instead of 8 hospitals struggling to try and provide all these services themselves. We've taken all of the options, as I've said, and we have assessed them against a range of factors. The impact on patients, the impact on the Welsh Ambulance Service, the benefits this would bring in terms of our workforce problems, and also a comparative financial analysis. And when we did that, one of the options emerged clearly as fitting best against the criteria, and that was option 3. The University Hospital of Wales, Cardiff, Morrison Hospital, Swansea, the Specialist Critical Care Centre in Cwmbran, the Prince Charles Hospital in Merthyr Tydfil, and the Princess of Wales Hospital in Bridgend being a 5-centre option, with the other hospitals in the network providing the majority of services as they do now and providing local services for people nearby. But that's what we've concluded, and we want to know what you think. We've put all the data and information that we've used to reach our conclusions on our website so that you can see them and make your own conclusion. So that's focusing on the hospitals that are the centres, but what about the local hospitals? What would it mean for them? Well, for this to work and for the network to be effective, all the hospitals need to be open and busy and playing a very important role. But the difference from now is that they would not all be trying to do the same things. They would have different roles to complement each other. It means that we will provide as much care as locally as possible, but only if it is safe to do so, and we're really clear that we must stop providing services that may not be safe. 4 or 5 hospitals would provide consultant-led maternity, neonatal critical care, inpatient children's services, and doctor-led emergency medicine. All the other hospitals, and indeed these centres, will provide the full range of other clinical services, providing services for the majority of patients local to where they receive them, just as now. With these sort of changes, it's really important to consider the impact on different groups in our communities. In addition, we have a legal obligation to do so. So we want to make sure that we do consider the specific needs of all the people who use NHS services when we make any changes. And we're working hard to make sure we do that. In particular, we want to look at and minimise the impact on different communities, especially those in the protected characteristic groups. And we've worked closely with our equality leads to make sure that we are considering this carefully. We want to work with you too during this process to make sure that the option that emerges as the preferred option following this consultation is the one that will provide the very best care safely and sustainably for everybody who lives in South Wales and South Powys, who use these particular 4 services. So what happens next? Well, the consultation started on the 23rd of May, and at the request of our community health councils will run for 8 weeks until Friday, July the 19th, 2013. We would urge you to look at the information that we have provided and then to take an opportunity to have your say. All the responses we receive, however they are received, will be analysed independently of the health boards by an organisation called ORS, a market research company that has special expertise in working with health services. The analysis that they provide will be shared with the community health councils for the 5 health boards and the Ambulance Service Trust in September, and the health boards will then meet to consider a recommendation from the South Wales Programme Board for a preferred option to implement about the future of consultant-led maternity services, neonatal critical care, inpatient children's services and emergency medicine, or A&E. So how can you tell us what you think? Well, probably the best way is to fill in one of our questionnaires. This can either be done on paper, and there is a copy of it in every summary and full consultation booklet, or there's an online version on our website, www.wales.nhs.uk/SWP. That questionnaire asks some specific questions that we would be very keen to know your views on, but also provides plenty of space for you to give your own views on any of the other aspects of these proposals. And all of those views written on the questionnaires will be considered. But you can also write to us, and there's a free post address, South Wales Programme Feedback, PO Box 4368, Cardiff, CF14 8JN. Or you may choose to write to your Community Health Council, who are overseeing this process and represent your views. Contact details for them, if you don't know them, can be found on our website. We have a special email address box to which you can send emails, and you can find a full range of information, including all the supporting documentation and a great deal of the technical data we have used, on the website, which is available in both English and Welsh, www.nhs.uk/SWP, where you will find a choice of English and Welsh versions. The consultation document is available in other formats. These include Braille, Welsh Braille, Spoken Book, British Sign Language, and large print. If you'd like one of those, please do ring us on 0300 083 0020, where there is an answer phone, and if you leave your details, we will get back to you and can provide the information in a different format. There is also a Facebook page and a Twitter account if you wish to tweet about our ideas. Please feel free to do so. Everybody in the South Wales Programme would encourage you to look carefully at what is being proposed, because this is about the future of these services for the next 10 years or so in South Wales and for South Powys. We really do want you to take the time to tell us what you think, if you support our proposals or if you don't. And it would be helpful for you to tell us why you feel the way you do, so that we can reflect on that before reaching our preferred option. Thank you very much.